All right. Okay, good morning. Good morning. Good morning here in the United States. Good afternoon to people in Europe. Thank you for joining us today, Friday, for our evidence-based mental health Google Hangout on ketamine and bipolar disorder. This is the second in a series of 2 Hangouts that we've had discussing the use of ketamine for mood disorders, and we'll be joined today, as usual, by Andrea Cipriani, Associate Professor of Psychiatry at the University of Oxford. He's the editor of the journal Evidence-Based Mental Health, also by Rupert McShane, consultant psychiatrist at Oxford, lead for the ECT suite in Oxfordshire, and also the lead of the Clinical Dementia Network of the Oxford Academic Health Science Network, and editor for the Dementia and Cognitive Improvement Group at Cochrane, and also in New York by Dan Iosifescu, who's Associate Professor of Psychiatry and Associate Professor of Neuroscience at Mount Sinai Hospital, and the what is the name of your medical school again? Never mind. Dan is an expert in bipolar disorder, mood disorders. I've known him for many years since we worked together at Mass General Hospital. I'm Michael Ostacher. I'm Associate Professor at Stanford University in the Department of Psychiatry and Behavioral Sciences. And today we'll start with a review of the most recent Cochrane review by the Oxford group discussing and examining the evidence for bipolar disorder and its treatment with ketamine. Andrea or Rupert, would you like to put up the slides so we can begin?
Yes, thank you, Michael. This is a great opportunity for us to discuss an interesting question about one of the new treatments we have. Am I sharing the desktop? Can you see the slides?
Yeah.
Yeah. Yes, sir. Yeah. So today we present the second systematic review. Rupert and I, with other colleagues, have published in the Cochrane Library in September. We have published one review about unipolar major depression, and this one, the one we are going to discuss today, is about bipolar depression. And it's a great example because we have synthesized the evidence that we will show in a bit. But at the same time, it's a good example because we need to translate this information into clinical practice. And looking at the amount of evidence, it would be good and interesting to discuss how to implement this evidence in real practice, and that's the reason why it's a great opportunity to have 2 of the most famous experts in ketamine and mood disorder. I'd like to start the presentation, very brief presentation, presenting what we can find in the literature. This is a review by Carlos Zarate published in World Psychiatry last month, and as you can see here, basically what they report in this sort of narrative review is several randomized placebo-controlled trials about ketamine in bipolar and unipolar depression show that this drug is effective. And what we try to do is to apply more rigorous criteria in order to see what is really out there. And this is the review we published in September this year. A lot of people involved because it has been a huge amount of work in terms of retrieving unpublished data, not only for the primary outcomes, but also in order to have as much data as possible for also secondary outcomes. We had crossover trials, so we wanted to look at data and results before crossing over. So it has been really a teamwork here in Oxford with the collaboration of people also from London. And the first slide is the Prisma flow diagram to show that we started screening 1,500 references, but in the end, the actual number of studies included in the systematic review and meta-analysis is only 5. And on the right here, you can see that there are also we identified 3 ongoing studies, which is almost the same amount of studies we found and have included. So it's a developing field. It would be nice to understand from the experts where are we going to, but of course this is a review that has to be updated pretty soon. These are the data. We found data about ketamine, about memantine, and about cytidine. The most relevant are for ketamine, 2 studies, but as you can see from this forest plot, we are talking about 33 patients overall. So it's very, very, very tiny proportion of patients. And we reported in the same forest plot, this is the outcome response. We divided in the outcome response in response up to 1 day, within 3 days, and within 1 week. And the efficacy is for ketamine versus placebo is statistically significant only after 1 day, 1 day after treatment. After 3 days, the efficacy is still in favor of ketamine, but not statistically significant, and basically the same at 1 week, but as you can see, we have only 1 study contributing to this outcome. Of course, there is no heterogeneity because for all the 3 time points, the evidence is favoring ketamine, even though not statistically significant after 3 days. But at the same time, it's interesting to compare these results with the unipolar depression, where the efficacy of ketamine lasted for at least 1 week. So this might be something we can discuss, whether there's a difference between unipolar and bipolar depression from this point of view. If we look at the continuous outcome rather than the dichotomous outcome, again it's ketamine versus placebo. The picture is very similar, and data are in favor of ketamine until 3 days. So this difference disappears at 1 week. And this similar to what we found in the dichotomous outcome, and the degree of improvement is also something we might discuss, because we use the mean difference. So this is the actual difference in terms of points on the Hamilton rating scale. In terms of dropouts, we didn't find any statistically significant difference, but results tend to favor placebo over ketamine. Slightly different situation for memantine. So this is memantine versus placebo. We have 2 studies contributing to this comparison, but unfortunately only 1 contributing to the outcome until 4 weeks. We have the Lee study with outcome at 3 months only, and we couldn't find any statistically significant difference in favor of memantine, except this slightly statistically significant difference at 4 weeks, but I really don't know how to interpret this finding. Probably it's by chance. At least we couldn't find any strong signal in favor of memantine as response rate, and in terms of dropouts, as you can see, the 2 studies didn't show any real difference between memantine and placebo. So this is what we found in this review. So I'd like to open the discussion to the floor and ask the experts how to interpret this data and how to apply this information into daily clinical practice.
Yeah, I think that's great, and Andrea, I think it's very important work, and it's especially important because of how widespread the use of ketamine is. But not only that, but because of how difficult bipolar disorder is to treat in the depressed phase, and so the limitations for our ability to treat it really drive our need for new treatments, and the excitement surrounding ketamine is on some level well-deserved, and on another level needs to be taken with caution. Rupert, would you like to begin, perhaps?
Yeah, I mean, I think the key message there was in the caution that you demonstrated, Andrea, and I think it's good that there are 3 studies in progress at the moment that is clearly going to add to this data. The volume of evidence in bipolar is obviously a bit less than it is in unipolar, and I guess that to a certain extent reflects the burden of just the numbers of people involved, I guess, which is reflected in the numbers of studies that have been done. I had a quick look at clinicaltrials.gov just before, and this is a very dirty sort of look, and I could only see taking all trials really, just very dirty sorts. There are 7 trials in bipolar depression in ketamine, but there are 122 listed overall for ketamine depression. So that gives you a sort of sense of the balance of research effort. And just last week in the UK, the National Institute for Health Research issued a call for proposals to look at bipolar depression. And there's obviously an issue here about whether one's got enough efficacy data here to start to put together proposals for effectiveness trials, or whether one should be waiting for those 3 outstanding trials to report before developing those trials. So I think the key message is really that I'm afraid there isn't very much evidence about bipolar response that seems to match pretty much the evidence for unipolar. So I'm not sure in my own mind that there's, just on the basis of what we've seen so far, that there's even a signal really that bipolar is very different from unipolar in terms of the research data. But I'm more than happy to be corrected by Dan, who will know more about this than me.
So, I think one thing that we need to really underline is the contrast between the relative scarcity of the data, which I agree it's relatively scarce for the ketamine in bipolar depression as opposed to unipolar depression. A lot of the studies have been done in unipolar depression, including the ones here at the Icahn School of Medicine in New York. And the bipolar studies have been primarily been the ones that Andrea just reviewed. And at the same time, the clinical need, in my opinion, is much higher in bipolar depression, in the sense that there's significantly fewer other alternatives for treatment compared to what we would have for unipolar treatment-resistant depression. So I think that even with this relatively limited data, if we look across both the unipolar and the bipolar world and the effects of ketamine, we can safely assume that the effect of a single dose ketamine is relatively well proven, that it, as Andrea mentioned, it unfortunately only lasts for a limited period of time. So the great news is that it happens very quickly, and it happens in patients who had failed previous more conventional treatments. The bad news is that it doesn't last too long. And in my opinion, and I would encourage us to try to discuss this, the most significant unmet need is not whether to use a single dose of ketamine, but what do we do after a single dose of ketamine seems to be helpful.
And,
go ahead, Andrea.
No, I mean, what do you do clinically speaking? Because if you see a response in this kind of patients, well, I didn't mention at the beginning, but the trials are all as add-on treatment. So these patients are on lamotrigine, valproate, lithium, and they add ketamine or placebo, memantine or placebo. So they are difficult to treat patients. They respond to ketamine, single dose. What next?
Right. That point that you just made, that people are on other treatments, is relevant when we talk about the differences between how long does a ketamine effect last between, in unipolar studies, most of the studies have been done with ketamine alone versus a comparison, either saline or a psychoactive comparison like midazolam. Whereas in the bipolar world, everybody was on some mood stabilizer, and all of these medications have some weak antidepressant effects. So that may be the reason why we are seeing the statistical separation between the ketamine and the comparison group be a little bit shorter. Although it's always very hard to interpret these very tiny studies. So I think that as a rule of thumb, what do you do after that first infusion is either more ketamine, and then we can discuss what are the type of schedules for administering more ketamine that people have used in the absence of a lot of data for it. And then the alternative would be, well, can we use something else to make that ketamine effect last? And there are several studies currently underway, and there's a tiny study that was published in Journal of Clinical Psychiatry earlier this year, looking at D-cycloserine kind of prolonging the effect of ketamine after an original successful infusion. There's a study ongoing here at Mount Sinai trying to use lithium to prolong ketamine infusion. Some people are using dextromethorphan or combinations of it. So there's all sorts of things that people are trying, but there's really no great data. But we could still at least mention them. So
and how does it work? So you start lithium or D-cycloserine after the injection of ketamine?
Right, either after or in essentially at the same time, knowing that the effects of that oral intervention would only start happening, over a longer period of time.
So just to understand the study design, so it's ketamine plus, say, lithium versus...
Right, so the study that they published in Journal of Clinical Psychiatry, it's a group from Columbia here in New York, was a single dose of ketamine, and then responders were given oral D-cycloserine for a number of weeks. The study that we are doing with lithium, people are getting a first infusion with ketamine. If they respond, they are randomized to either lithium or placebo, and then they get more ketamine to get an acute response. And then the question is whether they will stay better longer while taking the lithium.
Right.
Rupert, do you have a comment?
Yeah, so I think that we discussed this last time just briefly, and I think that it's very important to see if there are drugs that extend the effect Anecdotally, and that's all it is, we've found a few patients with bipolar depression who've responded to ketamine, and when we've introduced venlafaxine, they've had a further boost. So, but I think that's, I was unsure with those whether that was to do with they'd had a partial response to the ketamine and then had a further partial response. So, you know, it's just anecdotal things, really. The other tactic that Dan alludes to is the use of repeated ketamine, and it seems, and this is entirely a prejudice. It's just a prejudice, but it seems to be a bit implausible that you would give one shot of ketamine, and that by adding in whatever the drug was, whether it was D-cycloserine or lithium dextromethorphan, Brastam, Acamprosate, any sort of glutamatergic drug, that any of those would result in a very prolonged benefit. They might prolong it a bit, and it's, as I say, it's just a prejudice.
Say a bit more about why what your skepticism is. Like, what, you know, I mean, if you want to talk about it mechanistically or otherwise, it would be helpful.
Yeah, I suppose it's just well, it's partly driven, I suppose, by the experience of giving repeat ketamine, which I think is the other alternative, what we find then is that or what people in various case reports have suggested is that sometimes people have had repeated intravenous ketamine at a wide variety of differing intervals, and have been able to be maintained well. Now, that sort of makes ketamine a bit more like a normal drug. You know, that's what you do with drugs, is you give them drugs, you give them again. I don't think it's so amazing that you know, sorry, I should say we have had one or two patients who, particularly at the start of their treatment, and this is, I'm now talking about in an anecdotal way about the clinical treatment, who have had really very long benefits before relapsing. Now that is just a few, and actually in those cases, certainly in some of those cases, when they have then relapsed, the duration of benefit, they have then had further good prolonged responses with further ketamine, but ultimately people who have this sort of malignant disorder keep giving them ketamine, and occasionally they seem to become resistant to it. Now that's not, I'm not sure that it's tolerance, but it may be something more to do with the disorder. Anyway, we've had 4 cases now where that's happened, and where we've stopped the ketamine and then later have reintroduced it, and they've responded again as you did before. So that's something I don't understand what that's about. You've got no idea, that'd be great. So that's one thing, and of course the problem with giving intravenous ketamine repeatedly is that it's a tremendous burden on the service. You know, if you've got people who can afford that and can travel into the clinic and take it every day, then they'll take it. Sorry, have repeated infusions. That's fine, but as a sustainable sort of option, I think it would be interesting to see whether any of the other routes of administration might provide a way of giving, you know, long-term relief without having to bring people in for infusions. And as you know, Johnson & Johnson have got a phase 3 program underway. They've got 19 trials, I think, in that program. They've got been awarded breakthrough status by the FDA. It's the only mental health drug ever to get that. And this is S-ketamine, which is just one of the enantiomers of ketamine. And in that trial, in that program, they're exploring the possibility that twice weekly intranasal S-ketamine might be something that could be used in a sort of long-term way. I think, and that's one possibility. Another possibility, which I also think is interesting, is the use of oral ketamine. Now, the bioavailability of oral ketamine is rather variable, as it is with intranasal ketamine. But I've had several very interesting conversations now with people in Australia, where a lot of this is being used. And there's an interesting book by somebody called Stephen Hyde, which I would recommend to you. It's an easy read. It's well written. Published, I think, a couple of months ago. It's called Ketamine for Depression. And in it, he talks about some of the various centres in where it's being used clinically. So that it's a nice collation of anecdotal evidence. And probably one of the places where oral ketamine has been used a lot is in Brisbane, and they've given over 500 patients oral ketamine, and a good proportion of those have been discharged well. So I think that's really interesting. Their model is essentially to give oral ketamine twice a week in varying doses. It's anecdotal, and they certainly acknowledge that, and they also have they align it with a particular set of psychoeducational sort of tips for people on how to manage feeling relapse. I think it is hard to research. So I think there are multiple possibilities here, multiple routes, and there are people who swear by intramuscular ketamine, and I know for a fact that I've heard that in some areas of America there's turf warfare going on between anaesthetists who think that you need to give it intravenously and others who not anaesthetically qualified who give it intramuscularly or indeed orally. So I think that there are reasons why people develop opinions. And I have some opinions.
Yeah. But
what we could do with actually is some decently funded big studies. And I think that there's a real issue about how the funding agencies view the existing evidence, given that it is, as Andrea has shown today, it's very small, very modest in terms of the amount. And there's a disparity between that and really the conviction of those of us who are in the field that the consistency of the evidence really does point to a very very definite effect. So,
well, I mean, Rupert, I think that's really important to mention. I think one of the things that we were hoping when we started this Hangout today was to talk a bit about practical clinical the use of bipolar. The problem is that evidence for making such. Am I echoing? Or is it,
yeah.
Can you, So go ahead, Dan.
Yeah, as you're going to fiddle a bit with your... Oh, I have the same problem, apparently. Can you hear me well?
Yes, you're coming over well, Dan.
Okay, one thing that we need to mention is that there is some limited data, mostly open studies, for repeated administrations of ketamine, but even those tend to be for a relatively limited period of time, and they're mostly copied from the ECT administration regimens. Now, we are going to have, as you mentioned, the much larger study that Johnson & Johnson is conducting on using ketamine administrations up to 12 weeks. Those data have not been yet shared, and the phase 3 studies are still ongoing. But it is very interesting, and in my experience, what most clinicians here on the East Coast of the United States are doing is to administer several ketamine infusions in relatively quick sequence, 2-3 per week the first week, and then for patients who respond to that regimen, they would administer a few more, and then schedule some maintenance, either by trying to see how long is the effect lasting for that individual patient and having them return once they start relapsing, or by scheduling intermediate doses of intranasal ketamine. We have actually, even here at the Icahn School of Medicine, published a study where we had some decent effects with intranasal ketamine, not the S-ketamine that Johnson & Johnson is pursuing, but the regular racemic ketamine. I think that of the different methods of administration, bar the IV, which is the best way from a pharmacokinetic and absorption, but it's much more tedious, probably intranasal offers the best next step. I think that we looked carefully, and the oral administration is still associated with a very high variability in the absorption rate, so you really cannot tell what dose is being administered. The issue of the dose is also an important one, because for the longest time, and all the studies that we have reviewed that Andrea had included in his analyses, both for unipolar and for bipolar, the vast majority of those studies just include a specific dose, the 0.5 milligrams per kilogram. There is now a study that's currently ongoing, both here at the Icahn School of Medicine and at several other places in the United States, where we are trying to compare different doses of ketamine and see whether one of them would be more helpful. But I'd be interested to hear, Rupert, what you guys are doing. I know that my clinician colleagues here in New York, when they don't get good benefits with the 0.5 milligram per kilogram, they would go to a significantly higher dose in the range of 1.0 milligrams per kilogram, and not give up until they have no effect at both of these doses.
Yeah, that's broadly what we do. But the majority of people do respond at 0.5, who are going to respond at 0.5. So where as we develop a sort of knowledge and develop a protocol, the current position is that we're offering 2 0.5 milligram per kilograms infusions, and then if they don't respond to that, or if there's a hint, then we give a 1 milligram per kilogram infusion. If they don't respond to that, then we tend to say you're a non-responder. So they get sort of three goes at it. The reason for giving 2 at 0.5 milligrams per kilogram, it really arose from the experience of the case series that we did. We had several patients who didn't really seem to get a response in terms of their changes on their depression scores after the first one, but they had a sort of sense that something was about to change, and it certainly did after the second one. So, you know, one could make an argument for stopping after 2, because I'm not sure how many. I think there are people that seem to need a higher dose, and the anaesthetists, the pain anaesthetists who use a lot of ketamine, will tell you that, you know, if you're using an anaesthetic, then, you know, the dose that you need to use will vary widely and needs titrating for the individual. And I think that's also going to be the case whatever route you use, because whether it's for reasons of variable absorption in the individual, or whether it's because you know, the individual has a different pharmacodynamic sort of response to the ketamine, we are going to be in the business of titrating people both for the intravenous dose and intranasal and or whatever things. So titration is a fact of life, and it's really a question of. I think the frequency issue is also an important one. I've certainly heard the reports that you described of the East Coast practice, which I think is very interesting, and they've got lots of experience. And there are some people in New York who've got an enormous amount of experience using of this, and as well as using the intranasal, though, the sort of routine ketamine clinics, if you like to call it, they sometimes actually send people away with oral ketamine up to 200 milligrams, in fact an average of 200 milligrams, and some people are giving it daily, and other people, as I've alluded to already, are giving people suggesting that a sort of twice a week regimen might be adequate, and we certainly don't know which of those is better. You have no idea.
So, Rupert, you mentioned 0.5 twice. The interval between the 2 infusion is standardized, depends on the Westerns. Is there any? Yeah,
so we don't know really, do we? I mean, as Dan said, in New York they're giving it 3 times a week to start with, and I think there's some sense in that. We tried giving it either once a week for 3 weeks or twice a week for 3 weeks. Didn't seem to make much difference, certainly in terms of the ultimate duration of response. But you know, this was just a case. You know, it's not.
Rupert, I'm really interested in your report of having patients who seem to become resistant to the drug, but most interestingly, that when they're re-challenged with it and when they're dosed with it later, they seem to respond again. Can you talk a little bit more about that? Because my concern about all of these studies is that no matter how well blinded we try to make them, there's still this effect where people know, they have to know on a certain level that they're getting the ketamine. And that's true in a lot of studies, that people know that they're getting the study drug. It doesn't always translate to a benefit for the drug. I mean, there's an interesting trial, for instance, of ziprasidone for generalized anxiety disorder and bipolar disorder. In that study, 100% of participants who were on ziprasidone correctly guessed their treatment assignment. 100%, and yet it did not separate from placebo. So I am concerned about a placebo and blinding effect here, nevertheless. But talk a little bit about what happened with these patients, because I think that sort of suggests perhaps that it may not be just an unblinding effect where people know what their treatment assignment is, but in fact that people can become resistant in some way, and when re-challenged might be able to be getting benefit again.
I mean, I'm really interested in what Dan says about this, but I will just say very briefly, there's not a lot I can say about the resistance beyond what I've said already. You know, it's just it's an observation. I haven't really seen people getting obviously tolerant in the way that you would with opiate. But what I had done, because I wasn't very confident, I hadn't pushed the dose up. It may be that they did. Maybe if I pushed the dose up, they would have become tolerant. They would have then maintained the response. So your tolerance is certainly a potential issue. In terms of the blinding, I think that the key thing that I'm wrestling with, really interested in what Dan says in this you're going to do a long-term study with repeated ketamine, what is your placebo going to be? Because would you run into trouble with developing tolerance to your midazolam? Dependence with midazolam. If you're doing midazolam twice a week, you potentially run into dependence. So we, for what it's worth, and I'm interested in any comment, is thought that we'd use just something slightly sedating like promethazine to try and initiate some sort of psychotropic effect that was not antidepressant.
Yeah, and what do you think?
So I just want to make 2 points. One is to highlight something that Rupert said earlier, which was that, in my opinion, one of the advantages of ketamine is that it works fast and that you also can tell relatively quickly whether it's going to actually help or not a specific patient. In a study that we published here at the Icahn School of Medicine a couple of years ago, we did open ketamine treatments up to 6 infusions, and we found that individuals who didn't respond to the first or second had a very low chance to respond further on. One of the problems with that study is that we kept the dose fixed. So I still think that it makes sense after the couple of infusions that they didn't respond to try a higher dose, just as Rupert was mentioning. But it's going to be very quick that you're going to figure out this is or is not a good treatment for this individual, which to me is one of the problems that we're having in general in psychiatry and in bipolar disorder in particular, that these treatments take a very long time to prove a benefit or lack thereof. Coming back to the other issue of what's going to be the right comparison in these repeated dose administration studies, that's a very difficult question to answer perfectly. I don't have a huge problem with the midazolam, although it's not a great, but it's in my opinion, a good enough comparison so far. And yes, the issue is to get something that would be somewhat mildly sedative and would not have any dramatic antidepressant effects. And the fact that you would give midazolam several times a week doesn't strike me, especially since it's a relatively low dose, doesn't strike me as a huge problem, especially given the very short half-life of this medication. But obviously there could be other answers to this. So low dose doesn't strike me as a huge problem, especially given the very short half-life of this medication. But obviously there could be other answers to this. So low dose doesn't strike me as a huge problem, especially given the very short half-life. But obviously there could be other answers. Maybe one of us needs to start talking and.
Yeah. We're having a little trouble with our. We're having a little trouble with our sound.
Maybe one of us needs to start talking and.
Yeah. Trouble with our. We're having a little. Yeah. We may have to go offline and then back online again. I wonder if that would be helpful.